All right. Hello, everyone, and welcome to today's International Online Spinal Cord Injury Research Seminar. Surprise! I am not Warren. This is Stephanie Candilis. We figured it was time to give Warren a break since he's been hosting nonstop since these things started. So I'm broadcasting today from Seattle, but your broadcaster is different. We have a same great talks lined up for today. So first we're going to have a message from Dr. Geoffroy, who's going to tell us a bit about the what's going on in the Outreach and Publicity Committee, and then we'll have our talk by Dr. Matthew Budde, moderated by Dr. Anand Murthy. Then we'll have a couple of announcements afterwards, so please stay tuned. And with that, we'll bring in Dr. Geoffroy.
Hi, well, everybody, good morning or good evening, depending where you are. So today, just want to give you a quick update of what we've been doing at IOSCA, and specifically in the Outreach and Publicity Committee, or the OPC, as we call ourselves, although I'm more like an axon regeneration guy. So in random order, so the committees includes Karim Fuad from Edmonton, Warren Alliland, that you all know, Lawrence Moon from King's College in London, Bethany Gondiles in between Seattle and Vancouver, myself from Texas, Elisa Gonzalez-Rote from Florida, John Jensel from Kentucky, and Adam Dolman from Vancouver and the ICORD. So pretty international team here. And just I just wanted to quickly mention what we do in this committee. First, as I'm sure you all have seen, we created a new logo, as you can see here on the right, and I want to thank Cecil Martin for this awesome logo. So every Mondays, you receive different announcements by email. And if you're not on the mailing list and you want to receive it, either contact the onlineSCIseminars at gmail.com, or you can email me as well, and I will add you to that mailing list. We recently took over Twitter, so if you want to follow us, again, IOSCAs on Twitter, we put the announcements on Friday, and so you guys can get excited for the next week's seminars. We're starting developing the speakers highlight and the research synopsis with Laura Mendenhall in Warren's lab. Usually this comes over the weekend, so you can check it out during the weekend. We recently started rotating the Twitter banner with the speaker images. So if you're on the lineup for the next speakers, you will be receiving some emails, so you can start thinking about potential images, drawing, or anything you think interesting for the Twitter banner. We are developing we don't have a website yet, so we're developing a website. And the main goal is to keep track of all the past speakers and the past moderators, and keep track of the next speakers lineup. And down the line, once we have the green light from the speakers, we would like to repost the seminars so people can go back and check the past talks. And so what we do next, we want to increase our social media presence. We want to have more people watching us, and not only the spinal cord injury scientists, but also the community at large. And we want to increase on the international part of the name. And for that, we want speakers from everywhere. And we are already in contact with several people in Australia, New Zealand, in Japan, and Korea. And we want to increase even more this international aspect, because the IOSCA is a fantastic tool to hear from people all over the world that we rarely see, or once every 4 or 5 years. So we really want to enhance this good aspect of this IOSCA. And well, that's what I wanted to talk about. If you have any questions, comments, or concern or anything, again, you can see the emails on onlineSCIseminars@gmail.com, or you can also email me at geoffroy@tamu.edu. And that's what I wanted to say. So Bethany, it's all yours again. Thank you.
All right, great. Thank you very much. So now we're going to bring in Anu, who's going to be our moderator today. And I will let you take it away.
Okay, thanks, Bethany. So it's my pleasure to introduce today's speaker, Dr. Matthew Budde. He joins us today from the Medical College of Wisconsin, where he is an associate professor in the Department of Neurosurgery. His main research interest is to develop and use high-resolution imaging techniques to understand injuries and diseases of the nervous system. So he's used these techniques both in rodent models and in human patients with spinal cord injury to better understand the recovery process, and he'll be sharing some of his work today. Before this, Dr. Budde got his PhD in neuroscience from Washington University and did his postdoc right across the street here in Joseph Frank's lab at the Clinical Center at the NIH. There he applied high-resolution imaging techniques to understand the pathology underlying ischemic stroke in humans. He's had his own lab for almost 9 years now and has won many awards, not just for his science, but also for being an outstanding educator. So without further ado, I'll pass it on to Dr. Budde. I'm sorry, just some housekeeping stuff before that. As usual, please type any questions that you may have in the chat box or the comment box, and please preface it with a Q so that it's easier to spot. Over to you, Dr. Budde.
Thank you, Anu. Thank you, Bethany. I want to thank the organizers. I really enjoyed this forum and these series of talks. And hello, viewers on YouTube. I think when many of us can feel really isolated during quarantine, it's nice to come together still as a research community and tackle some of these difficult problems facing spinal cord injury. So most of my work will talk about the acute setting in animal and human studies. And so I like to start out as kind of a framework and kind of a vision for what we hope will happen in spinal cord injury, and reflecting on what has happened in stroke and how imaging and imaging biomarkers have played a role in stroke and improving public health. So in the 90s, it was shown by Mike Mosley early on that diffusion MRI was a new technique at the time, and it very clearly showed an infarct here in an animal, which was not apparent on conventional MRI. So there was some unique information with this new technique that had immediate clinical implications. In the 90s and since then, perfusion and diffusion MRI were combined into methods that identified the region of salvageable tissue, also called the diffusion and perfusion mismatch here. So this identified that if there was an intervention available, at the time there wasn't, but if there was an intervention available, that's how much of the brain could be salvaged if that was successful. And sure enough, in 96, TPA was approved for less than 3 hours, and endovascular therapy was approved for less than 8 hours in 2004. And in the last decade or so, we've seen a really explosive growth in the number of studies that have expanded this window, this treatment window. And I want to point out that many of these studies use perfusion imaging and some of the diffusion-perfusion mismatch to identify those patients that were most likely to benefit from a therapy. So I think in framing that in our perspective, that's kind of what we're trying to do. It's the unfortunate reality that not all patients with spinal cord injury have the capability for recovery. But if we can identify those that do, it might help us identify promising therapies that we can take in patient settings and have a potential impact in improving patient outcomes. So this is a very imaging-centric view, obviously, but imaging was used for diagnosis and prognosis and then in therapy guidance. So translational science, right, this is the nice linear flow that we all hope to achieve. But there's some hurdles along the way. This is affectionately known as the valley of death, from what I've come to learn from basic science to clinical research. And moving into clinical practice has been termed the first mountain of despair. And the second mountain of despair is going from clinical practice to better patient outcomes. As we all know, this is not a linear process. We have dead ends and we have twists and turns along the way. But hopefully what we're trying to do is emerge from the laboratory setting to improve the lives of patients with spinal cord injury. So getting into spinal cord injury, the current diagnostic recommendations for imaging and diagnosis is that CT is recommended to identify the bony structures that are affected, fractures and stenosis and things like that. But MRI actually, based on the 2013 clinical guidelines, has a really low evidence for T2-weighted MRI because it has a limited prognostic ability and it really doesn't change management or patient outcomes. And so here's an example from Brian Kwan's lab, where they looked at what's called the intermedullary lesion length, or the length of the edema on a sagittal scan. And they didn't see that was a strong predictor of whether someone improved their neurological status 6 months later. It was clear that hemorrhage or hematoma length seemed to be more predictive. So already, even with conventional imaging, we see there might be two different classes or some imaging signatures that reflect how well patients might recover. So the outline of my talk really focuses on diffusion and more recently perfusion MRI and spinal cord injury. So we'll talk a lot about, we develop in animal models of thoracic spinal cord injury and cervical injury. And you see the trainees listed that have done all the work in each of these respective areas listed to the right. And then I'll show some early work that we have in patient studies of acute spinal cord injury and follow it up in the last half of the talk really to talk about what we've done with perfusion and angiography to developing those techniques to make them hopefully clinically translatable. And the major questions we aim to address, we still take, even in the animal, we take a really the perspective of a clinical scenario. So can diffusion MRI be improved for better reliability? And really importantly, I think, does it reveal new information that might be useful in patient management? So even if it's a good technique and reliable, hopefully that provides something new to the treating clinicians to help them guide how they treat patients. Perfusion MRI of the spinal cord is a much less developed methodology, so those questions are a bit simpler. How does spinal cord blood flow? Can we measure this non-invasively with MRI? And how does that change after spinal cord injury? And then putting these two together, again, do these advanced imaging techniques provide unique information that is different from what is already done in the clinical setting? Lastly, what I won't talk about, but as you can imagine where this is all headed, is can these MRI markers predict outcome and can they monitor therapy success, both in animal models and hopefully in human studies one day? I'll point out that all of our animal protocols, our MRI sequences that we use are available for download. Anything that we've published, we put up here, and once we do publish something, so if there's diffusion techniques, if you happen to be a preclinical researcher interested in imaging and want to download some of these specialized things, you can go to this website and do that. All of the GE tools that we develop locally are facilitated through what's called the collaboration database, where GE sort of facilitates sharing amongst different institutions and licensing agreements and things like that. So I promise this is the only slide that really gets into some MRI physics, but I think it's important to understand because I'm talking so much about diffusion, how this actually works. So diffusion MRI is actually just measuring the thermal motion, just the random walk behavior of spins or water molecules within a tissue. So this is not flow, it's not perfusion, but just thermal Brownian motion. And it's very clear that here's an electron microscope image of an axon. What happens is that the axonal barrier impedes diffusion perpendicular to this axon, but diffusion is relatively free along this, as one might expect. And so getting into what actually we're measuring and how we do this, let's say, for example, we have some static particles. And what MRI does is it tags them based on their spatial location with a phase. So we encode some phase. And if they're static, we simply undo that phase and we obtain a measured signal. Now, if the particles are moving, we do that same encoding. But if they happen to move during this time period in between, now when we do that rephasing, there's a loss of phase coherence. So that leads to some signal decrease. And so literally what we're doing is we're measuring the signal decrease. And we can relate that back mathematically to our displacement of our particles with some knowledge about the diffusion encoding that we're using. So in this case, a larger signal decrease means that water is diffusing faster or has a higher diffusivity. And based on the directional dependence or shape, we can derive some estimates of what's called anisotropy. So here's an image of the spinal cord where you can see in the white matter we have high fractional anisotropy because the white matter fibers are oriented along the spinal cord. And in the gray matter, we have a much more isotropic distribution microscopically, and that leads to a much more isotropic detection of the diffusion within the tissues. So diffusion does have some history in spinal cord injury, obviously, and without summarizing all of it, preclinical diffusion imaging and diffusion tensor imaging consistently shows high sensitivity and specificity, and it's used in a number of different scenarios. But really, this has not made its way into patient settings. So there's really, maybe less than 10 published reports of really rigorous DTI studies. There's a lot of case reports. There are many technical challenges with imaging, and diffusion imaging in particular, the size of the spinal cord, the magnetic field, and it's prone to motion. And one thing that this talk will really focus on is how edema confounds the diffusion interpretation. So here's an example of one case study. It's a 32-year-old male from a car accident, and you can see the conventional T2-weighted MRI shows a really long lesion length here, going up and down the cord. But on a single diffusion-weighted images, this is a much more focal injury. And so when we quantify things like ADC, or it's also called mean diffusivity, we can see that injury, but in the regions of edema, we also have effects that might complicate this interpretation. And FA is one of the most popularized and most sensitive techniques. But as we can see, this changes throughout the whole length of the cord as well. So while FA is a sensitive marker, it's not very specific for that real discrete underlying injury. And so that's one challenge we wanted to tackle. MRI is also challenged by after surgical metal hardware is placed. It's more difficult to get images, and I'll talk a little bit more about that. However, there was a really nice study out of the University of Maryland where they did diffusion tensor imaging, and they showed that a measure of diffusion parallel to the cord was a great predictor, actually, in this data set of 1-year neurological outcome. So there is some strong evidence, at least in the human, that this is a useful technique, and this can help potentially prognosticate better than what's currently available. There are many challenges, again, with the image quality, and so they measured outside of the discrete lesion here because of hemorrhage and artifacts and other things like that. But this is promising that DTI, at least, is making its way from animal studies into clinical research studies. So again, going back to stroke, some of my work as a postdoc was to look into why diffusion changes after stroke. And so maybe for about 20 years, the field was really debating about what's the nature of these changes. And I think what changed that was many of these studies were doing in vivo microscopy. So here's an animal, I believe a mouse model, where the dendrites express, a subset of dendrites express a fluorescent protein. And within 4 minutes after a stroke in this animal, you can see this whole dendritic field take on a very different microscopic feature, which is called varicosities, or we just call it neurite beating. And in fact, it becomes a bit self-evident then, if you have structures that resemble this, more like small spheres, that diffusion is now restricted in all directions, whereas in the normal case, water is free to move up and down the cord. So this gives some evidence about axonal beating or neurite beating as really underlying the diffusion changes in stroke. And we went on to investigate that a little bit more with some biophysics, and it's sort of, I want to kind of bring this together, that neurite beating and cytotoxic edema are kind of the same flavors of the same thing. So when we modeled this, we can see a video here of the biophysics as these neurites swell. And the one thing we learned from this is, so as if we constrain the surface area, this leads to a volume increase. So we suspected that because of the osmotic imbalance, that water is swelling these neurons, that this is a passive response for the neurons to accompany that increase in volume without drastic elastic membranes or something like that. So a number of years later, from a mechanistic standpoint, Stephenson et al. Kind of came to this similar conclusion that dendritic beating results entirely from excessive water influx. So again, kind of pointing at a passive mechanism. Ranga et al. Did some really nice work looking at not only is this driven by sodium influx as it enters the neuron, but also the role of chloride here. So blocking chloride channels reduce the neuronal swelling. So basically, this is what's driving it, is that an excess of salt intracellular, and that drives water with it to lead to neuronal swelling. And another follow-up to that study using biophysical modeling again, and I won't go into the details, but I think one important concept that emerged from this work is that the cell can tolerate a pretty strong change in membrane potential up to a certain point. And once it hits that tipping point, it really tips into a more osmotic equilibrium. So there's two stable states here, a pathologic equilibrium and a physiologic equilibrium. And so the implications of that is that what they described is that In order to get back from this pathologic state or this injured state to the normal equilibrium, it requires two things: not only a block of the pump activity, like you would like reperfusion in stroke, but also a blockage of the sodium and chloride influx. So it's kind of like a flood, right? If you have a flood in your basement, for example, you need to pump out the excess water and block more water from coming in. So this might have implications in spinal cord injury as well, but I think there just hasn't been enough work to really understand all of that. So sure enough, Williams et al., using a similar in vivo preparation in a mouse model, was able to show that after 2 hours, in this case, the axons taken a very similar beaded morphology. So again, this looks like a very common feature across multiple different injury or disease states in this. So the question then is, how can we use diffusion imaging to really understand this? If we know what's driving the diffusion changes, how can we specifically tailor the experiment to understand that? So many approaches, and I think we've done this for a long time, is trying to understand, well, if DTI changes in a certain way, what pathologies does that represent? And my personal view at this point is that it's hard to identify a certain universal set of features that reflect that. So we've kind of taken the different approach with that. How can, at least in the spinal cord, how can we make diffusion imaging more sensitive and specific to beating? In the presence of edema and other things going on in the cord. So what we did is a simulation of these beaded neurons and went through a whole list of different diffusion models and different metrics that one can estimate. This is a running list of acronyms in the diffusion imaging modeling world. It's starting to resemble molecular biology a little bit with all these different nuances between them. But basically, when we run this through an analysis, we came up with a sensitivity analysis. And this tells us, is this metric that we're estimating, is it sensitive to volume fraction or neurite density or edema? Or is it sensitive strictly to beating? And you can see here a continuum of different markers. One thing to point out is that DTI, really again, as I've talked about, is not uniquely sensitive or specific to either edema or beating. It's complicated by both. And one feature that did emerge was something, a parameter that's estimated from a technique called double diffusion encoding. And I'll get into that a little bit and how we use that for our spinal cord. So what we've called double diffusion encoding or filtered diffusion encoding, again, our goal is to see if we can disambiguate healthy and injured axons and minimize the confounding edema. So here you can see a schematic of that. In our healthy cord, we have just axons lined up. And the blue indicates our extracellular or edema in this case. At the site of injury, now we also have injured or beaded axons, as well as probably some normal axons, and probably even much more edema and extracellular fluid. So with some knowledge of the diffusion physics, basically all we did here was just apply a high diffusion gradient or diffusion encoding perpendicular to the spinal cord. So what that does is, because the extracellular fluid moves faster than the intracellular fluid, at least in this direction, that suppresses all of the extracellular and edema signal. And now we can come back with a second measurement to measure parallel to those fibers. And so this is where the nomenclature double diffusion encoding came about. We do one thing in the perpendicular direction and then measure something else in the parallel direction. And so here's a healthy rat spinal cord without this filter and with this filter. And one thing you can see is that this is still the same animal in vivo, and this is suppressed everything except signal from the spinal cord white matter itself. So again, this is kind of proof of principle that this technique works in the healthy cord. And so when we first took this to a thoracic spinal cord injury, Nathan Skinner did this work, we saw some really encouraging results as well. So again, we get two metrics here. One is after the filter or diffusion weighted image. And the second is a measure of parallel diffusion along the cord, but filtered or uncontaminated by the extracellular fluid. And you can see here very clearly that there's a central region of injury surrounded by a peripheral region that, at least at first glance, appears to be much more preserved. We've tended to like combining these into a color image, which very clearly then shows red is injured and this green or yellow color is healthy. Just to show some reliability across different animals. So each one of these panels, each one of these subpanels is a separate animal with an axial slice taken at the injury epicenter. This was at 48 hours post-injury. So you can readily see where the damage has occurred in most of these animals. And one thing to point out, even if this is a nominal mild injury, some of these animals might look more like a moderate injury and vice versa. And clearly you can see just across the whole set of animals here, just the extent and the magnitude of the injury. So this is encouraging that we can see this in individual animals and make sense of this as a technique. Following up on that, a little bit of confirmation, and I'll point out that a lot of the intricate details and the results and methods are in this paper by Nathan Skinner. At 30 days, what we saw is we don't see any more evidence of ongoing or acute axonal injury as one might expect. And 30 days later, we see comparable lesion volumes in, for example, a severe injury and a mild injury. But that's the axonal content here is really predicted by what we saw at 2 days. Looking at some animals, a small group of animals sacrifice at the same time point as the imaging, we see, in general, a qualitative correspondence here. We see this peripheral rim of white matter that seems to be relatively preserved. And in a mild injury, we see more of a dorsal column injury, which is reflected by the in vivo imaging. Another similar related concept is when we talk about chronic spinal cord injury. Now we don't have this ongoing degeneration anymore. We're just left with either axons or non-axons. And so the same concept applies. We just apply diffusion at multiple different strengths here. And from that, we can estimate what's called the axonal water fraction. So it's a diffusion technique to estimate how many axons are left within that voxel. And just again, qualitatively showing the same animals, we see much more intensity in the mild animal, clearly reflecting that we have a much higher density of normal axons histologically. And even though we have the same amount of overall tissue here, we can see a lower intensity in the severe animal, reflecting that we have a lower intensity or lower density of axons within this preserved tissue. So putting this all together, Natasha Wilkins, when she was in my lab, did a comprehensive study looking at 1 day post-injury, 30 days post-injury, and 90 days post-injury, looking at our diffusion measures of acute injury, markers of axonal water fraction, as well as quantitative T2 to reflect edema. And so what I'm showing on the right here are correlations at each of those time points with the strongest MRI metric. So at 1 day post-injury, our diffusion measurements, or filtered ADC, was most strongly correlated with locomotor assessments BBB score at 1 day injury. At 30 days, we saw that the residual estimate of residual axons was more strongly correlated with BBB score. And interestingly, at 90 days, we showed that the lesion volume estimated from just a more conventional MRI was the strongest correlate. So this really is, in hindsight, is not too surprising. It follows what we know about axonal degeneration. So early on, we have injured axons, but they haven't degenerated. At 30 days, there's some mix of healthy axons and degenerating axons, as well as glial scarring and other pathologies. But at 90 days, at least in the rat, the residual tissue is a strong correlate of the overall neurological status. So the second corollary question to that is, how well do these acute measures predict chronic outcome? And so these MRI markers at 1 day post-injury, we showed that diffusion, not surprisingly, showed the strongest correlation with long-term functional outcomes. So it shows its prognostic value. T2 was also significantly correlated. So I think in combination, these two have much more information than probably one alone. So Sung-Yi Lee in my lab has also looked in this more recently in cervical injury at 24 hours post-injury in a cervical model in a rat. Just showing again qualitatively that we can see with some nice clarity the discrete lesion we see in a unilateral injury or a midline injury here affecting the white matter. And again, just to point out that DTI does detect this, right? So we can see a decrease in our diffusion measurements here, but we also see a slight increase adjacent to that, which is probably some effective edema, vasogenic edema. And again, traditional DTI parameters of AD, it's not that they don't show the injury, they do. It's just a little bit harder to interpret than perhaps something like this in both the unilateral and the midline injury. So Spencer Murphy has then taken on this project to try and translate this into human patients. And so this work was graciously funded by the Nielsen Foundation to take what we've done in the animal models and see if we can get similar results in human acute spinal cord injury. So here's what things look like on our nice state-of-the-art research scanner, a 3T system with all the nice gradients and hardware and coils. And we can get really nice measurements of diffusion parallel to the cord, comparing that to DTI parameters, showing that we get similar variability. We get a slight decrease in our measurements, but overall this is consistent with what we're seeing in the animal. And so the clinical reality of this is that we're not scanning these patients on our state-of-the-art MRI systems. We're doing this on usually 1.5T systems in the hospital. And in the case of injury, we have other artifacts that come in, imaging artifacts, and the cord is deformed. So the question is, how do we even begin to assess that at the site of injury? And one technique that we developed, so using the same diffusion principles, we're using a different readout. So instead of trying to take an image, what we're doing is a single voxel that encompasses the entire cord and getting a spectra from that. We can estimate diffusion based on that single voxel rather than trying to draw regions on an image or deal with imaging artifacts. And when we did this, we tried to assess how immune it would be or how much it would be affected by changing the magnetic field. So what we did is deliberately perturb the system. And so our imaging, we lose our signal in the spinal cord, and it just leads to poor ability to even capture an image there. And even our spectra were much broadened, but surprisingly, we ended up getting the same or very similar diffusion values here. So even if we have really bad spectral widths and bad spectral quality, we still can get reliable estimates of diffusion here in just a small subset of sham animals versus severe. So there is some tolerance using this technique to hemorrhage and magnetic field changes. So we were encouraged by this and also applied this in the human setting. So here's what that study looks like. Here's a workflow, basically. So any patient that comes in that's eligible and is screened by our enrollers and has had a neurological exam and usually a CT. If they're going to a clinical MRI, we attach on an 11-minute research scan with these diffusion techniques. And then they follow the same standard of care, get their Azure exam as they normally would. And then they come back 6 months later for both a research MRI as well as another Azure exam in that setting. So here's some early work. So this is really what keeps me up at night is can we get our techniques to work, or these specialized techniques to work in a hospital scanner, which is no small challenge. And so here's an example of one patient that we enrolled, a 44-year-old male in a motor vehicle collision, and they had a C3 Asia B incomplete. So you can see that our image quality here is not bad. I mean, I'd like better, but it's not a bad place to start. And you can perhaps see a little bit of a decrease in our ADC parallel. We might also see that with our DTI acquisition. So we're doing a side-by-side comparison showing those. And so also trying to ensure that we have sufficient signal to noise to obtain reliable estimates here. And so Spencer putting this all together from a small cohort. Basically, the outcome from this is that this filter diffusion technique shows a unidirectional change. So it shows a decrease at the site of injury relative to regions adjacent to that, whereas DTI has sort of a more fluctuating appearance here. And so here is that plot relative to our highest segment. Our filter diffusion has about a 75% decrease at the site of injury compared to DTI, which is about a 15% decrease. So again, that's not always the case. In some cases, where in this patient example, we have a fracture dislocation. Even at the site of injury, we're not able to get good quality images. And so here's where our spectroscopic technique comes in. Again, this is early data. We don't have sufficient numbers, but above the cord, we see an estimate of diffusion that is roughly approximately what we find in the healthy cord. But at the site of injury, we see a more dramatically reduced diffusion measurement. So at least in this context, I don't think that a single spectroscopy technique is probably the answer in terms of its direct clinical translation. But it's at least evidence that if we can solve some of these other imaging problems with trying to get images of the cord, that diffusion might give us some information about what's happening at the site of injury. And related to that, I want to highlight some work by Kevin Koch. He's the director of our imaging center here at MCW, and really specifically looking at how we can optimize some diffusion techniques and improve them to actually image the cord in near metal hardware. So here's an example with the multi-level surgical hardware. Our traditional EPI diffusion weighted images, there's nothing that resembles the cord here. But using his specialized techniques that he's developing, we can see something that at least looks like the cord contour here, albeit with lower resolution, but it's at least a step in the right direction. So with that, I will pause for questions here if anyone has anything.
So we've got two questions. The first one's from Bradley Lang. So rather than FA, what about the individual diffusivity indices that make up FA?
Yeah, so axial and radial diffusivity, are those that go into making up FA. So axial diffusivity is a stronger marker of axonal injury. Radial diffusivity, at least in the acute setting, doesn't seem to provide a lot of additional information. But AD can still be contaminated. So if we have excess extracellular fluid, that can still contaminate. And actually, a lot of people have found that we have increased AD in some cases relative to what we would expect. So by filtering out the extracellular component of that, we think that it's AD in our cases, it's the same measurement, but it's more specific to the underlying tissue damage rather than being a feature of edema.
Thank you. So the next question is from Hadi. So what about, based on your results, which type of SCI animal model is more similar to human pattern change?
I mean, at least in our data, we don't have enough human data to really, talk about that. I think there are many clear differences between the animal models. As I'll talk about at the end, what we're using is a contusion injury model, but that may be very different for example, some of these patients have a prolonged decompression, compression of the cord. So I think some of these models that people are developing with sustained compression is probably more realistic to what happens in the human situation. So other than making generalities, I don't want to comment too much about, the animal models have their limitations, certainly.
Okay. And the last question for this now is, what is the longest scan time that could be accepted for routine use clinically?
So thanks for the question, David. So the techniques that we're doing, so we add 11 minutes, and that includes 2 separate diffusion scans, as well as 4 of our spectroscopy measurements. And so really, ideally, we want to get this down to about 5 minutes. I think 5 minutes is a tolerable scan. And I'll talk a little bit about that. I think if we optimize the diffusion settings, I think we can get to that or even lower. Again, in an acute setting, it's got to be quick and it's got to be reliable. So I think 5 minutes is tolerable, but if we can, basically if we focus on the things we want to extract from the data, and with knowledge of that, I think we can get down.
Okay.
Okay. All right, thanks for the questions. Keep them coming. Happy to I love chatting, and I love conflicting points of view. So if you have those, please share them. We want to make the science better. So the other unmet clinical need that we sort of latched onto is perfusion of the spinal cord. And so blood pressure maintenance, again, based on the 2013 guidelines, maintaining blood pressure for the first 7 days is recommended with strong evidence. But it's really not clear, and there's a really limited number of techniques to actually monitor what's happening at the spinal cord rather than just the systemic map pressures. And so one technique that's been reported a number of times by this group and others is to insert a probe into the spinal canal under the dura to directly monitor perfusion with the technique. Although, this needs invasive placement during surgery, although it gives continuous monitoring. And so we wanted to develop MRI to see if we could monitor more directly perfusion in the spinal cord. And so trying to understand the vasculature of the spinal cord, I know this is probably a review for some of you, but it helped for us to understand what's happening. So at least in the cervical cord, blood flow branches off of the subclavian into the vertebral arteries, And there's multiple segmental arteries that then feed into the cord and frankly meet up again with the anterior spinal artery that runs the length of the cord. And those are what actually penetrate the anterior aspect of the cord here. And so the gray matter is largely perfused by these penetrating sulca arteries that come off of the ASA. And so there's three sort of techniques that we've looked into. They're all based on the concept of what's called arterial spin labeling. Again, so we're using magnetic properties of the blood to tag the blood, and that gives us some estimated perfusion. And so these are all techniques that don't require exogenous contrast agents, so there's no injection. It uses just intrinsic signal based on the magnetic properties. And two of what I'll talk about, what I'll focus mostly on is this technique called pseudo-continuous ASL, which is by and large the most recommended technique for brain imaging, so it has most of the work associated with it. And what we do there is simply put a label plane where we tag the blood, so any blood that's flowing through that gets a magnetic tag, and we can monitor that with the appropriate control condition. Briefly, what I'll talk about is some other work that we've done in the past looking at what's called FAIR, or flow alternating inversion recovery, where we perturb some region of the cord, and by watching this signal change over time, we can get an estimated perfusion. And really what I think might be most valuable for the cord, although our preliminary data I'm not showing it here because it's too preliminary, it tags the blood based on its velocity properties. So blood is moving at a much higher velocity than most of the other tissues in the body, and we can use that to tag specifically the blood. So going into first this FAIR technique. So what this does, this is done by Somtek Lee. For those microscopists, it's a lot like a FRAP experiment where you basically perturb the system and watch things recover. So in this case, perfusion makes its way back into the tissue, and we can take a series of measurements there. Here's kind of the raw images that we get, again, thoracic cord, so we can see a bit of gray matter here. And as long as we have our label condition and our control condition, actually what we're measuring is a property called T1. But from those differences, we can extract an estimate of spinal cord blood flow. So here at least you can see some evidence of higher blood flow in the gray matter, which is what I expect. It's a little bit noisy. Certainly in the severe case, we've lost any sort of anatomical contrast. So we just take a whole cord measurement here. And this is really, again, a bit uninterpretable, but we get a whole cord measurement here. And what he showed is that with increasing severities, we do see at the site of injury decreasing blood flow, which is probably what we might expect, but with higher variability. So we think there's plenty of room for improvement on this technique. And actually what he showed is that T1, which is generally a good marker of edema as well, showed a much more consistent relationship with the nominal severity here. So going back then into PCASL. So Brianna Meyer has done a lot of work taking this from what's really not been reported in the spinal cord to taking it to what we think is a pretty viable technique. So the first step of that, again, is to understand where do we label the blood. And so in this case, we first did an angiographic scan. And basically the results of this show that at C6, where the vertebral arteries enter the spinal cord foramen and are in the transverse foramen through here, lower than that, they come at the spinal cord from some odd angle. But so C6 is the lowest segment that we feel comfortable that we can get reliable blood tagging in this case. And so here are the quantitative results here, showing how they deviate as we go much lower in the cord. So everything that we're doing is tagging at C6. That poses some limitations on what we can do, but it's at least a good start to get reliable results. So as I've alluded to, the traditional way of capturing images is what's called echoplanar imaging, but you can see here in the sagittal plane, there are a lot of prominent artifacts at every disc that leads to these real distortions. However, we were a bit encouraged that we did see perfusion in the gray matter here, just maybe with not the best image quality that we were looking for. And so what Brianna did is take the same tagging principles and converted that to what's called a fast spin echo or a rare sequence, which really has inherent properties that limit the amount of distortion that we get. And so this is really something that we were really encouraged by. We could see very clear perfusion in the gray matter here relative to the white matter. And this technique gave us really high signal to noise. And so we could trade that in for some even higher resolution here. So here's what this looks like in a healthy cord. You can see here, here's the anatomical image, and then here are 3 maps of spinal cord blood flow in quantitative units. And as we vary the delay between when we tag and when we image, we can see in general, we can sort of higher perfusion at the more segments closer to the label plane. And as we increase the delay, we can see perfusion reach higher levels in the more proximal segments of the cord. So this is really encouraging. This is, certainly something we celebrated with a happy hour. And so then we first applied this to a contusion, a cervical C5 moderate contusion injury, where here's more of the anatomical imaging again, and you can see the extent of edema here. But what was actually somewhat surprising is we saw a real focal perfusion deficit. And what we didn't see was, even if we wait longer, we didn't see blood ultimately reach that segment. So this is, at least our interpretation, is just a complete loss of perfusion in this tissue. But if we sort of outline the contours here, the perfusion deficit was much more focal than what we saw with the edema. And so hopefully this is giving us more information about the, the focal extent of the perfusion deficit. The other thing we were concerned about, and one thing has to consider, is how long do we wait after doing the tagging. And we noticed some really strange patterns when we used a technique called time-encoded pCastle, but basically that gives more finer temporal sampling. And so you can see here early on, after a short period, high perfusion in these segments close to the cord. We even saw at C3 a region that has high perfusion there, but with this gap in between where perfusion is much more delayed relative to the other segments. The same thing at C2. We saw this region that really didn't fill in until very long, much longer after. So we thought that these were basically watershed areas where blood flow is the last to reach these segments relative to those adjacent to it. And to help us understand that, Songtaek Lee took that same pCastle technique, and instead of trying to measure perfusion, actually measured angiography of the arteries that supply the cord here. So here are the 2 images of a label and control. You can see some evidence of the vasculature here, but when we do a subtraction, and these are images of different delays and different dilations and durations. And you can see here, as we, with short delays, blood flow is still in the vertebral arteries. But as we increase these delays, we can see even some of the segmental arteries and even the ASA. And so we can convert this whole data set into a map of what's called the blood arrival time. So this tells us in milliseconds how long blood takes to reach each one of these arteries. And so again, what we saw here is this segmental artery here at C5. What it looks like, at least in our view, is a bifurcation. And so it's feeding both an ascending part of the ASA as well as the descending part of the ASA. But the segmental artery at C3 was really just feeding the ascending segment of the ASA. So again, even in this vasculature, we saw regions of watershed regions with delayed arrival in the angiography scan. So it kind of points to why we see the perfusion differences that we see. These might become important, for example, if injuries occur at different segmental levels and how that feeding vasculature plays into the perfusion deficits. Just because these make for nice movies here, here's an example of a healthy animal. And so here's our bright region of tagged blood, but we can see this as it flows into the cord. If I stop this, you can see again these real hot spots here, here, and here. But as we go out in time, we can see that perfusion generally does start to fill in almost all of the cord. And after a certain period, the blood flow has really made its way through the capillary bed and flows out through the venous system. In the injury, you can see kind of a similar pattern where we saw early onsets of perfusion in a couple areas. We see it here, and not so much here in the injury site. But again, as we watch this play out, we didn't see any strong evidence here of perfusion eventually reaching this injury. So it's a real loss of perfusion rather than a delayed perfusion. So putting those results all together, quantifying these across different animals, these line plots are the whole spinal cord as a distance from the mid C6 level where we're doing the tagging. So the edema, what we see is obviously we have a high amount of edema at the site of injury. And what we were a bit surprised to see that this edema, as measured by quantitative T1, really seems to propagate. It's significantly different than the control cord, all the way throughout the higher levels of the cord, which were a bit surprising for us, but maybe not terribly surprising. Perfusion, we can see across a couple animals, a real perfusion deficit as we expected. This is really consistent at the site of injury, but really nothing above the injury site that gave us any evidence that there were perfusion abnormalities extending beyond this, the level of injury. And I think it's important that we looked at also the transit time, so the ATT's arterial transit time. And so we saw an increase in the transit times here at the site of injury, but it really wasn't pronounced relative to the perfusion deficit. So moving forward, I think it's more important to monitor the blood flow rather than, for example, in some cases like in stroke, where blood flow can be really delayed, but it's still well perfused. So we didn't see any evidence of that in this injury model. So putting this all together, just a few slides left. So what is the relationship then between diffusion and perfusion in the spinal cord injury? And so Sung-Yi Lee has done a lot of work, again, starting out with something that looks pretty abysmal like this, to developing what's called a diffusion prepared or fast spin echo technique, where along with some motion compensating and control of the cardiac delays where we acquire the images, a really relatively artifact-free image of the diffusion-weighted spinal cord here at really high B value. So putting that all together, this is relatively hot off the press, I think just from last week, showing a couple animals where we were able to capture both of these images with the same orientation and the same type of readout. So these are matched perfectly in space. So again, one thing to point out that I've talked to before, that it's a little bit hard to see the lesion here on the map of parallel diffusivity, in both these animals. It's a little bit, while they do show changes by about 25%, it's a little bit hard to see with the naked eye, whereas with our filtered diffusion technique, which is measuring also, again, diffusion parallel to the spinal cord, this becomes immediately apparent. But what we did see is that, again, perfusion deficit was far more focal than our diffusion deficit. I believe this is at 1 day post-injury. The second animal is probably a little bit more mild injury, but again, our diffusion abnormality extended well beyond what we saw in our focal perfusion deficit. So trying to bring this back to human studies, and so one thing I think I've learned, I know there's a question about how do we do this feasibly in a clinical setting. I think some of these techniques to reduce artifacts, I think, are going to be important. Many people are working on this, and we're certainly not the only ones. But I think trying to optimize these B values or diffusion-weighted imaging for the cord, if we're specifically looking at acute injury. Here's an example from our animal studies where if we do what's typical in the spinal cord, a B value of a certain value of 700 or 800, we get a lesion to normal contrast on the diffusion-weighted image of about 25%. But when we optimize those, taking the same number of images, we can increase that to about 65% of the contrast here. So potentially a radiologist looking at these images with an optimized set of B values and directions might be able to better see the injury more so than what we're doing traditionally. And so that change on normal scans with the diffusion-weighted EPI really only requires a minor change of the B value table, what's called, on the system. But I think some of these spin echo techniques, both diffusion prepared and perfusion PCastle, one nice thing about quarantine was that I was able to work on programming these, but we haven't been able to get back into our scanners yet and test these on human patients. But I think this could be really fruitful if we can demonstrate what we have done in the animal, taking this forward. So putting that all together, diffusion, to summarize that we see acute lesions, and if we optimize this, we can see acute lesions in individual animals. And our early human results are consistent with what we've shown in the preclinical setting. I think we're very optimistic about the role of perfusion MRI in spinal cord injury. We can see a clear and demonstrated deficit at the injury site. And I think the remaining questions for animal studies are how do these evolve early after the injury? But really, can we use these techniques to both look at promising therapies, and can these detect early changes? So if we give an animal something after 4 hours, and that stabilizes the diffusion lesion versus an animal that hasn't received that, can this help us inform much earlier and facilitate acute studies in the animal model? But I think the overall goal here is to really develop, if I vision a long-term goal, it's to pre and post-surgical advanced MRI to help establish their clinical utility and what kind of information they can provide in terms of managing the patient and ultimately providing better outcomes for patients with such a severe injury. So I want to acknowledge all of our collaborators here. I especially want to point out, in addition to all the students and trainees that did the work, the help of Robin Ferger, our study coordinator, who has really been instrumental in coordinating and managing all these acute human studies. So with that, I'm happy to take questions and look forward to the discussion. Thank you.
Thanks, Dr. Budde. David Magnuson says beautiful work, and he wants to know if you've tried or thought about combining perfusion imaging with something known to alter vessel diameter or vessel compliance, IH or hypercapnia maybe.
We've probably entertained the idea, but we have no direct, we haven't planned any studies to look at that. More of what we're looking at is more of the vasopressive agents right now. So can perfusion detect changes after those agents are administered? Again, mirroring some of the work that Brian Kwan has done with his implanted probe, can we non-invasively measure a similar type of phenomena? We haven't looked specifically at diameters or compliance, but it's an interesting idea that I'd be happy to talk about later.
Okay. Andrew Smith wants to know if diffusion imaging is possible in humans with post-surgical fixation.
With the caveat that I'll say yes, with the caveat that those techniques are really in their early stages. So again, I showed one slide with Kevin Koch, who was a former GE employee who developed the techniques to minimize the artifacts in conventional T1 and T2 scans. He's now working on techniques to integrate that with diffusion imaging and those same techniques. So the other thing I'll point out is that our animal work with these spin echo techniques are more compatible with those artifact reduction techniques than, let's say, an echoplanar imaging. So I think we can get there. It's going to take some work and some ingenuity to make that a reality. But I'm confident that can move forward. But it's going to be a long road.
Okay, and Warren Alilan wants to know if you've initiated studies combining your imaging techniques with some experimental approaches.
If I'm reading that right, I think he's maybe alluding to interventional techniques. And so, yes, we do have plans to integrate the imaging techniques, something with neuroprotective. Yeah, so a couple of the, a study that we're about to be funded for is looking at a couple different therapies in the acute setting, basically latching on those that have shown already strong preclinical results and are already in phase, one of them is in phase 3 trials in the human spinal cord injury. So taking those well-established techniques and to implement those and see how those change early on after injury with the imaging biomarkers. Yes, we do have plans to look at those.
Okay, so that's with the questions. Thank you so much, Dr. Budde. And I hope all of you can join us next week on the 30th, a week from now, to listen to Dr. Ona Bloom from Northwell Health.
Okay, thank you so much, Anu. Thank you, Dr. Budde. That was a really great talk.
I did get kicked out, actually.
Yeah, we had a little behind. We got kicked out, but we persevered. So thank you very much. And
Awesome.
I believe
Dr. Budde.
Dr. Budde will be in the chat to answer a few more questions. But
Awesome.
before we pop off to that, I just want to quickly say a big thank you to Warren and Megan, who really just got this whole thing off the ground. This is the first time that they have not been solo running the show, doing these seminars. So I think,
and it's awesome what you pulled off today.
And so from the whole of the community, we want to say thank you to Warren and Megan for everything that you've done. And now we will turn it off to the chat. We'll end the official broadcast, and we will see you all next week.